Okay, hello everyone. My patient for this week for my subnote is going to be on a neurological problem in a geriatric patient. So, MD is an 88-year-old female. She's accompanied by her husband, who is an established patient at the clinic. MD and her husband are reliable historians. Patient states, I fell twice while on the toilet, and the second time I really did a doozy. MD presents to the clinic after falling twice while on the toilet during the middle of the night, both episodes within 1 week. Patient reports falling forward and hitting her right side of her head during the second episode 3 days prior. So this was on March 18th, 2023. Patient notes that she had a laceration that was bleeding. She complains of constant eye pressure and redness with a mild headache since her second episode. She rates her pain a 3 out of 10 in severity, and she has been taking oxycodone for symptom relief. So, patient was seen in the office 1 month ago for iron deficiency anemia. She denies any loss of consciousness during the events or after, changes to her vision, fever, nausea, or vomiting. Patient's pertinent medical history consists of chronic back pain, constipation, chronic kidney disease stage 3, fibromyalgia, elevated liver enzymes, and generalized anxiety disorder and depression. She is allergic to Bactrim. MD currently takes ferrous sulfate for anemia, oxycodone 5 milligrams, and pregabalin for fibromyalgia, semistatin and zolpidem, or also known as Ambien, 10 milligrams for insomnia, and escitalopram, 10 milligrams for depression and anxiety. Past surgeries for MD include a right knee replacement in 2012 and a rectal prolapse in 2015, and no recent hospitalizations. Her last mammogram was in 2019, her last colonoscopy was in 2017, and her most recent DEXA scan was in 2019. And all these were normal results, no abnormal findings. She has a family history on her father's side, or her father, for heart failure. Her mother had arthritis and type 2 diabetes. MD denies any recent or past illicit drug use, smoking tobacco, or alcohol consumption. She drinks a cup of coffee a day, and she does not exercise. She does report that she needs to improve her diet and drink more water because she only consumes a few glasses of water a day. She lives at home with her husband. She sleeps about 6 hours a night with medication, and she has two living children. So, review of systems. Constitutional. MD reports feeling just mediocre today. She denies any fever, chills, no changes to her weight. She denies syncopal episodes, denies weakness, numbness, or seizures, reports occasional dizziness and constant headache, and reports feeling unbalanced. HENT, she has no difficulty hearing, no ear pain, no sinus issues or congestion, no sore throat, no bleeding gums, no dry mouth, denies any blurry vision or changes to her vision, and reports that she has not seen an ophthalmologist recently. Cardiovascular, she has no chest pain, no shortness of breath at rest or upon exertion, no palpitations, and no known heart murmurs. Pulmonary, she denies any cough or wheeze. For her derm, she denies any hives, rashes, or lesions. She does report that bruising and swelling of that right eye and her right eyebrow. Psychological reports increased melancholy just due to the event and feeling off balance. And musculoskeletal, she denies any muscle aches, no muscle weakness or back pain. She does report arthalgia in her right knee. Gastrointestinal, she denies any changes to her bowels. She denies any nausea, constipation, or diarrhea, and denies any cervical lymphedema. She does report easy bruising. So vitals today, she has a heart rate of 87. Her BP is 132/72. Her temperature is 97.6. Respers are 16. Her pulse ox is 94%. She is 5'4". She weighs 120. Her BMI is 20.8, and pain is a 3 out of 10. So her physical exam, general appearance today, this patient is well nourished for her age and appropriate to the situation, and no acute distress. HEENT, normal cephalic. She does have that closed laceration and contusion of her right eyebrow and forehead, just right here, with bruising and swelling. Her right eye, she does have subconjunctival hemorrhage in that right eye, but not in the left. Her left eye is, the sclera is white. Bilateral arcus sinalis. Both eyes demonstrate pearla. Tympanic membranes are pearly gray. Her hearing's intact. Her lips and mucosa are moist, no erythema, and her nose is patent. So neurological, she does have a shuffling gait and uses a cane. This is not a new onset for her though. Cranial nerves 2 through 12 are grossly intact. Normal strength, normal tone, sensations grossly intact. Fine tremors in the upper extremities, which have been there for a couple of years, she notes. Reports memory, remote memory is normal, and she's oriented to person, place, situation, and time. So her neck is supple. Cardiac, she has S1, S2, regular rate, regular rhythm, no murmurs, gallops, or rubs. Extremities, no cyanosis, no edema. Pulmonary, she is clear to auscultation, and she has good air movement throughout. Musculoskeletal, she has no bony abnormalities, no contractures. She does have limited range of motion in her upper and lower extremities with joint tenderness, but she does have full motor strength and tone. She does not have any rashes, scars, or ulcers on her skin. She has good skin tugger. She does have that right orbit bruising and laceration of the right forehead. She is in normal mood and affect, and then lymphatic, she does not have any enlargement or tenderness of her cervical lymph nodes. So assessment, we're going to be talking about differentials here. So differentials, my first differential and leading one is specified adverse effect of medication. This is a polypharmacy-induced fall. So you have an additive effect of zolpidem, which is a sedative, in addition to a opioid, which she's taking oxycodone. So you put the two of them together, and you're going to have increased CNS depression and sedative effects. So MD is an older adult. These individuals have decreased drug metabolism and clearance, which increases their sensitivity to medications on top of already taking to CNS depression type medications. So patient reports consistent use of both these medications almost every night, which leads to my leading diagnosis. So her second differential is going to be syncope and collapse, a vasovagal response, which is a sudden temporary loss of consciousness that causes the inability to maintain posture due to inadequate blood flow to the brain. This is due to those recurrent falls while she's on the toilet in the middle of the night. Possibly she's straining, she's bearing down, causing that vasovagal response. However, this is less likely the differential here because she denies ever having loss of consciousness during both events. And then the second differential is hypotension. So orthostatic hypotension is a fall in blood pressure characterized as a decrease in systolic blood pressure over 20 millimeters of mercury or diastolic over 10 millimeters of mercury from a supine to standing position. So this is pretty common in elder patients. However, this patient is not taking any diuretics or alpha blockers or even blood pressure medication, and her orthostatics today in the office are normal, so this can be ruled out. So final diagnosis for MD is specified adverse effect of medication, also thought as polypharmacy-induced fall in a geriatric patient. In addition, she has the diagnosis of repeated falls, laceration of to the head, and contusion of the right eyeball in the orbital tissues. So diagnostics for MD today are going to be a CBC, a CMP for electrolyte imbalances and adequate hydration, a serum B12 and folate, and TSH will be useful in the evaluation of that peripheral neuropathy. And orthostatic challenge, we're going to be doing that. Take the BP laying down and while standing up. And you do this while she's standing up for 3 minutes and then compare those vitals between the two. And then a CT of the head without contrast is recommended for patients who sustain a head injury, especially for an older patient like this. Treatment is to help MD wean off opioids and the Ambien and eventually do this, a little bit, maybe one medication at a time. Do this too because they both increase the risk of falling. And try some non-pharmacological techniques to reduce her chronic pain, like heat therapy, stretching, massage, medication, or those kind of things versus medication. We also want to prevent future falls for MD by advocating the importance of exercise, so decreasing those falls by improving strength and balance, muscle tone. So exercise is really good for her. She's going to have a referral to an ophthalmologist because we want to make sure she's doing that eye exam evaluation. If there's anything significant or redness in the inflammation, that we need to make sure there's something else going on, verify there's no other complications. Education for MD will consist of limiting the consumption of opioids and sedatives to only as needed, and then reduce environmental factors that increase the risk of falls, such as rugs in the homes, improper footwear, possibly like she's wearing slippers that are slippery on the tile, so having good traction, removing any clutter around the house, using night lights and adequate lighting throughout the home, especially at night, and then address any sensory impairments, including glasses, make sure they're next to her bed so she can pick it up and go use the restroom. Um, importance of adequate hydration and prevention of hypovolemia. And then we really want to make sure she's following up in 1 to 2 weeks to assess that head laceration, make sure it's healing properly, review those labs, make sure nothing's abnormal, and also the CT, and evaluate effectiveness of non-pharmacological methods for pain and management. And her and her husband will be cautioned to follow up in the ED if there's any sudden changes to alertness, because this will prompt further imaging at this time. All right, thank you very much.